Hello, good afternoon to everyone. It's a pleasure to be here, and I wish I had an opportunity to meet each one of you, because that's one of the things that I find most interesting at the Aspen Ideas Festival, not just the presentations, which are wonderful, but the dialogue that ensues, and it's, for me, has been very, very inspiring. They asked me to introduce myself, so that's what I'm going to do, since I'm a very obedient person. I'm Nora Volkow. I'm a doctor, I'm a psychiatrist, and my job is I direct the National Institute on Drug Abuse, which is one of the institutes at the National Institutes of Health, whose mission is to develop knowledge and science that can help us prevent and treat substance use disorders and understand the effects of drugs in the brain, and ultimately, what is it that makes some people become addicted to drugs and others do not. So it is, that's what I do from the perspective of my administrative job. My work as a scientist, I'm a clinical neuroscientist, and I work with brain imaging to try to understand what are the changes in the brain of people that become addicted, and that information is very, very relevant because it can then help guide us for therapeutic interventions. And also how much there is there in terms of diversity. So when we speak of addiction, we cannot sort of say this person that's addicted here is the same as this person that's addicted over there. And I'm going to just use that to emphasize also that when we speak of pain, we cannot homogenize all of pain, and pain is tremendously heterogeneous. And that's what I'm going to be speaking today about. And you'll start to say in yourselves, well, what is it that an institute director that basically funds research and devotes her life to addiction and drugs has to tell us about pain? Well, pain is extraordinarily important for us as an institute. In fact, over the past 2 decades, we have dealt into the most severe crisis that we have ever faced in our country for addiction, and that's the overdose crisis. Starting in the late 90s and proceeding forward over the past 25 years, we have seen a significant rise in mortality from overdoses driven by the use of opioids. And that crisis that reached its height in 2022, with actually approximately more than 110,000 people dying from overdoses, most of them driven by opioids, what is initiated by what I consider a horrible neglect by us in the healthcare system for the management of care of people that suffer from pain. And thereupon, the interest of our institute to understand actually what is driving pain, because pain that is not properly treated can actually lead a person to much greater risk of using substances as a means to actually escape the devastating emotional inner experience of having severe pain. Also, the other reason why we're linked to it, and then I'll detail it a little bit more, is that the most powerful medicines that we currently have for severe pain are opioid medications. And I don't know if anyone, I guess it's very difficult to go through life without having a severe pain insult, but I recall that I was in a terribly bad accident, and my leg was completely and utterly shattered. And I remember the intensity of the pain, and I wanted to just lose consciousness because I couldn't deal with it. And then the doctor came in and says, Nora, I have to give you an opioid because we have to reset your bones. And he gave me the opioids, and everything was extraordinary. I mean, it was, and I'm not exaggerating. An opioid makes you sedated, and I was forcing myself not to allow myself to fall asleep because I wanted to live every single moment of that experience. And that gave me an insight about how powerful these opioid drugs can be. And the drug that they injected me was Demerol. So it also made me recognize that I am a person that's particularly sensitive to those rewarding effects of opioids. The pain went away. It was no longer an issue. It was for me to try to remember and experience that moment so very much. Now, turn around to my sister, and you give her morphine. She's having a difficult surgical procedures, and she starts to vomit and gets nauseated and just cannot tolerate it. So that is an aspect that differentiates. Not everybody has the same response to opioids. But those people like me that get an opioid for the relief of pain, actually that enjoy it, are a particularly higher risk to transition into having the addictive process settle in their brains. And I was so scared. They hospitalized me, everything. And they kept me on opioids for the whole 2 days and a half that they kept me there. But when I left the hospital, me studying addiction, of course, I said, I don't want any of this, and I stopped cold turkey, which is not a recommended thing to do, but I did. And it creates tremendous amount of anxiety. Be it as it may, now I know the experience of what opioids are. But for us in the field at the National Institute on Drug Abuse, it became the overdose crisis made us very, very aware that we needed to shift the paradigm and to advance the science of understanding pain, and importantly, to bring treatments that are not just relying on opioids that don't have the addictive potential. Of course, we have other medications, and some of these medications can be extraordinarily valuable for the management of pain, like non-steroidal anti-inflammatories, some of the antidepressants, some of the anti-epileptic drugs. But there are still many patients that actually are in pain, and many patients that still the only intervention that actually helps them is are opioids. So therefore, it's not something that we can neglect in the whole field of addiction, because it's a factor that actually we need to address if we want to prevent and treat opioid addiction and other substance use disorder. But it's also interesting and important, because when you have that commonality and you say, okay, here we have an extraordinary aversive response, severe pain. You have a burn, you have this one of these massive burns that are horrifically painful. And at the same time, you have a medication that you can give. You use morphine to treat people with pain, and that's actually the way that we were doing it in the past. And it helps them. If you don't treat the pain, they can go into cardiovascular shock and they can die. So you need to treat, it's an emergency to treat the pain. But this same medication, morphine, can be extraordinarily pleasurable. So what does it tell us about the neurocircuitry in the brain? And I think this is also very important, because it gives us an understanding of the linkage. Now, how relevant was it, just to get for you a sense of how important was the overprescription of opioid medications in driving this opioid crisis? Again, neglect from the healthcare system of providing the research and the investments on development of pain treatments, but also neglecting addiction. In medical school, still in many medical schools, you don't get taught how to recognize if a person is addicted or not. You don't know how to treat them. So what happens? There was a very influential paper that came up in the late 90s in the New England Journal of Medicine in a small sample pilot study that showed that patients that were with pain treated with opioids did not get addicted. And that opened up Pandora's box, because then we all, clinicians, became very complacent, and because the New England Journal of Medicine, stating that if you have pain, you are protected from becoming addicted to your opioid medication. And that is not correct. Actually, right now, we know that in and of itself, pain can act both in some people to enhance the addictiveness, in situations where there's nothing helping, where it's so reinforcing to remove the pain when you take the opioid, that may actually make it more rewarding. But in others, it doesn't. So in fact, it may attenuate the rewarding effects of morphine. So it's not, as again, you're going to say, is not a universal panacea, but they are interacting. So look at the overdose, the prescription numbers. Opioids, this is hydrocodone, this is oxycodone, and you can see these 30 years, actually 20 years, the significant rise in prescription of opioids. And that was a lot driven by this sense that it was safe to actually provide an opioid with someone that's pain. Now, let's transfer these prescription increases from 1999 to 2010. So we have opioid sales in green. Look how it rose, how dramatically it rose. And it's not that pain increased like that in the United States over that period. Look at the overdose deaths. So this is why, I mean, in terms of it forces, so they called us in and says, well, we need the NIH to work on a plan to address the overdose crisis. We cannot be losing. And at that point, it was not so many. When we started, it was like 70 or 80,000 people dying every year when they gave us the money to address the overdose crisis. So, and I I spoke with the director of the NIH and says, yes, we need to develop treatments for people that have an opioid addiction and for treating overdoses, but we also need to address pain. And as a result of that, we've got an allocation of funding from Congress that has enabled us for the first time to have a source of resources focused just on the development and understanding of pain and the development of therapeutics that are effective for management of pain and that are non-addictive. And this reflects the whole gamut. So I'm speaking of medications, but there are also enormous amount of interest, and I was speaking here with Anna just now, in terms of neuromodulation technologies. So if you saw my big idea talk where I was basically speaking about let's harness neuroplasticity, this is very, very relevant for pain. Why? Well, let me put you just in a certain context. There's acute pain, and I'm not going to deal with acute pain because that we know how to handle. The problem is chronic pain. And chronic pain is that pain that lasts 3 months or more. And chronic pain has 2 categories, and I'm simplifying so that it can be easier to follow. One of those chronic pain that you have because you have a constant insult. So say you have autoimmune disease, so you have the inflammatory process going on, and if you don't manage it properly, that's going to be affecting your joints, that's going to lead to actually pain. That's there. And so it's not an artificial, I mean, I shouldn't call it artificial because all of it is real pain, but it's not an enhanced, it's sort of a pain that has been learned out of context. And then there's the other pain, the chronic pain, that is not, you no longer have the insult, but the pain is there. And that, again, from the perspective of understanding, has been fascinating to try to see what happens in the brain, that the brain continues to signal in the pain pathways that there is an insult, and that generates the response of pain. And so how you manage the chronic pain for which there is a constant insult, of course, is going to be very different from the way that you manage chronic pain for which there may be a sensitized, a strengthened creation of a synapse that's just signaling pain. And that's why these 2 fields are completely linked with one another. Pain and pleasure are inversely correlated. Pain, when you have pain, that diminishes pleasure. And when you have pleasure, that decreases the sensation of pain. So people that are living constantly with pain know this very well because they don't enjoy activities as they used to do before. But if they are able to get engaged, then they basically say, oh, I forgot about my pain. So this is because, again, the neurocircuitry that is engaged between these 2 processes is actually highly corresponding to one another. They actually, there's tremendous overlap. The other aspect about pain is that if you give an intervention, which is what I was just mentioning at, removing the pain then by itself becomes highly rewarding and reinforcing. So when we speak about rewards, we tended to think in the past about the whole sensation of pleasure, hedonic pleasure, but it is much more than that. It's that sense of well-being. And there's nothing more pleasurable than actually when you are in a state of discomfort, remove that state of discomfort. And we all live this in all our daily lives, but with pain, it is very, very clear. So how do we understand it from the perspective of neurocircuitry and mechanisms? Well, if we know that pain medications, the most effective medication in general, again, depends on the type of pain, but opioids for severe pain, immediately they can work. By the way, you become tolerant to them, so you need higher and higher doses. So they tend to stop working. And so how do they act? What do they tell us about this whole neurocircuitry of pain? Well, we have our own endogenous opioid system, and one of its functions is to regulate pain. And it does it through these neurotransmitter systems, which are enkephalins, endorphins, and dynorphin. This one is considered by some to be part of this endogenous opioid system, others not, so I'm not going to dwell on it. And these 3 neuropeptides, they are distinguished neuropeptides, modulate areas on our brain where we signal both pain, and they also regulate areas in our brain where we signal reward. they are one of the main mechanisms. So we actually, for the effects of reward, we have the mu opioid receptor. So this endorphin binds to this, which is the protein that transmits the mu opioid receptors. This one here, I want to actually just concentrate on these two because they are the ones that are most relevant for reward and pain. Dynorphin acts through the kappa opioid receptors. So we have the mu opioid receptors and the kappa opioid receptors. And where are they located? Multiple areas of the brain. Importantly, for all of us trying to understand pain, we have to recognize that these are highly located on the periaqueductal gray. So the pain that comes from the peripheral part of your body into the brain goes through it, and it is regulated in this area. And you can see how important the mu opioid receptor and the kappa opioid receptor are there. Then they go to, we have high concentration of them into the amygdala and the hippocampus. Here is my amygdala, and here is my, I think, hippocampus, more or less. They are very close, the amygdala and the hippocampus. And the amygdala and the hippocampus are actually areas in the brain that regulate emotions. Your emotions, that's why it sort of says emotional reactions activate your amygdala. And when you are in pain, you can see the amygdala hyperactivated. And in studies in animals where you can inhibit different regions, if they inhibit the amygdala, the animal regains its normal behavior in an animal model of pain. So the emotional component of pain, I can never overemphasize, is crucial. And in fact, some of the therapies that are being developed is the attenuation of this amygdala response through pain. So if you can blunt that, the person can say, I feel the pain, but it doesn't bother me. And so that is therapeutically very, very helpful. But we also have two very important areas where these opioid receptors are located. This area here, ventral tegmental area. Why is this important? The ventral tegmental area is where the dopamine neurons sit. And the dopamine neurons are these neurons that get activated, and I like to call them the energizers. They energize because they motivate our behavior. So, and they do that through an important projection that goes into the nucleus accumbens. So this projection is crucial for this energizing element. And so it drives your motivation. And so you can motivate us or any other living creature two ways. You can motivate them by pleasure, by saliency. You can motivate them by aversive experiences, like pain. So that will actually activate these dopamine signals. It's sent it to the nucleus accumbens. And what happens then? That basically drives the behavior. If it's pleasurable, rewarding experience that motivates you to seek the stimuli. If it's aversive, it basically inhibits it. And so this explains why when people suffer from pain, particularly severe pain, it's much harder to engage on everyday activities, not to say even perceive them as pleasurable. But the aspect about dopamine, which is the BTA, the dopamine cells going into your nucleus accumbens, they also go prominently into the amygdala, and they go also prominently into the prefrontal cortex. But dopamine, classically, when we speak about it in terms of drugs, directly initially activates this pathway, and that's very rewarding. Pain also activates this pathway. It's slightly, if you go in and, of course, have a microscope and tune in, you realize that they are adjacent areas. It's not exactly the same area in the nucleus accumbens, but it's the same pathway. So what is this relevant? Well, we speak about dopamine as reward, but if you were there on my opening session on neuroplasticity, dopamine does something that is extraordinary. It actually, when it gets activated here, it generates a memory that is imprinted in your brain almost immediately. It's what we call conditioning. And that conditioning actually is brought about by the ability of dopamine to race very fast. And pain does it, so you get conditioned. So when you have pain, or when you take a drug, you're going to be conditioned on the environment where this is happening. And when you go back into that environment, you are going to be more likely, if you are taking drugs to all of a sudden have the desire to take drugs. This operates also with food. And so that's why when we're in certain environments, we immediately have a desire for a chocolate, a cookie, or whatever we ate there. But for pain, it can also serve as a trigger of pain. And this conditioning element is doing that by activating neuroplasticity. And so both drugs and pain trigger these neuroplastic changes. And you have heard in many of the sessions now that neuroplasticity is the mechanisms by which our brains change themselves. They actually can strengthen connections and weaken others. So when you want to learn something, you strengthen that connection. And when you are young, your brain is much more neuroplastic than when you are old. And this is why you can learn things much faster when you are very young than when you are old. But it's also why you are more at risk to become addicted if you are young taking drugs than later on, and why adverse insults at a young age can have very long-lasting consequences. Through research in the effects of drugs on this neuroplasticity, we've come to recognize that a similar process and pattern is occurring in pain that leads to the sensitization. And the molecular mechanisms are the same. How does dopamine do that? When dopamine triggers these signals, the dopamine binds to receptors that are located on excitatory cells. And the correspondence of dopamine with these excitatory cells actually modifies the expressions of receptors on the cells that they are communicating with. So a synapse is to cells like this. So this is my message. I have to transmit it to this one. Now, if I want to transmit very strong, I transmit a lot of neurotransmitter. But if this cell here has very few molecules that can detect it, that signal is going to be weakened. So the way that you strengthen the synapse is by strengthening the receptors here. And this creates what we traditionally know as long-term potentiation. And long-term potentiation, again, is a process that occurs throughout our whole brain and is a key element, fundamental element of what we call neuroplasticity. Equivalently, you can degrade the protein expression on the membranes of these excitatory receptors, and that leads with long-term depression. So let's take pain. On pain, you can sensitize certain pathways so that there are going to be certain moments and actually certain emotions because you are conditioned. You've felt that pain. So the fear that the pain is going to be coming back is actually intensifies the emotional aversive state. And that is an aspect that, for example, therapeutically we try to teach the patients to help them overcome. And with drugs, similarly, we strengthen the synaptic strength of that, the association of taking the drug, not even that drug, it's taking that drug, the act of taking the drug with pleasure. And that synapse is basically immediately fires. But at the same time, we are not stimulating other alternative signals that then get degraded. And in the case of addiction, we know this, for example, is one of the reasons why people lose the ability to feel pleasure for other stimuli, why they disengage from their everyday life. And the same thing happens with people on pain. They disengage from many of them. If the pain is severe, it's very easy to withdraw and disengage from everyday life. So these mechanisms, again, are in overlap. So what are the consequences to our brain? Well, these pathways go from the center on the brain on the reward to our cortex, to our consciousness. And if they are sensitized and they are conditioned or they are weakened, how does that affect the brain? And which are the key regions? And I do want to guide you because, again, I think it's important that we all start to get an understanding of the landscape of our brain and our experiences. The insula here. The insula is an area over here that is very important with perception, in interoceptive awareness. So interoceptive awareness is you're hungry, you are thirsty, you are anxious, you have pain, you are on pleasure. So this area is fundamental for pain, as you may imagine. But it's also fundamental in many of the psychiatric diseases. So patients for depression, for example, that dwell a lot on that state of hopelessness actually have disruption and activation, hyper-involvement of the insula. The orbital frontal cortex here, on top of our eyes, here, is actually an area of the brain that distinguishes in a sort of conscious way rewarding from non-rewarding stimuli. It's not just the energizing effect of dopamine, but is this pleasurable or non-pleasurable as a function of context? So a stimuli that in one context is pleasurable can be very aversive in another. That is your orbital frontal cortex, and both of them are affected by pain. And then we have the amygdala and the hippocampus, both of them get engaged and affected. And then we have the anterior cingulate gyrus. And the anterior cingulate gyrus is an area here in the middle of our brain that is actually important for perception of pain itself, but it's also important for perception of drug reward, and it makes the computation on what you expect and what you get. It's the area of the brain gets activated when there is a discordance between what should be and what is. So these systems, all of them have been shown through imaging studies in humans that they are disrupted both in the case of addictions and in the case of pain. So what is this all about? Well, basically it's all about to tell us the same process that leads to reward, which is crucial for us to survive, because if things were not rewarding, we wouldn't have the motivation to go and get the food that we need for survival, or we wouldn't have the motivation to take care of babies. It's extraordinarily rewarding. They wouldn't survive. Or the motivation to find a partner with which we can ensure that the species will continue to reproduce. So, but what is the point of pain? Pain is also life-saving. If you don't have pain, and there are people, because of genetic mutations, don't actually perceive pain, and that actually jeopardizes their survival, because they can get hurt, and they tend to be burned, they tend to be crushed, and this, again, can be very devastating. So we have pain for a reason. It serves a purpose to protect us when something is harming us, to do the behaviors that are necessary to get away from that stimuli or to take action on it. So that's what it is. Of course, pleasure, dopamine, positive reward, behavioral excitation. Pain, dopamine, negative reinforcement, behavioral inhibition. And one of the aspects that we've also come to play in the whole field of addiction that is, again, reflects how these two patterns are so closely related. Many people that have, particularly whether it is nicotine or opioids or alcohol addictions, are at much higher risk of suffering from chronic pain. And that is actually much greater than in the general population. And again, people suffering from not properly managed pain are at higher risk of taking drugs in order to be able to escape that state that's very, very aversive. So, why is this all important, and where are we going with research? And certainly in the path, we are going in research in the path of understanding what is pain, how actually peripheral versus central pain, how many types of pain there exist, and how our own genetics influences the manifestation of pain, and how are pain part of medical conditions. How many people have pain, chronic pain? In the United States, 50 million. How many people suffer from severe chronic pain that interferes with their everyday life? 17 million. And yet it's a neglected disease. And so, and again, it's neglected not just from the perspective of the academic field itself, but also from industry. Why? Because we had opioids, and you could make much more of a revenue on developing alternative opioids and formulations, God bless you, and rather than investing on a process that has not been simple to come up with alternative treatments, because you then have to get them approved by the FDA, and you have to demonstrate a certain level of threshold of benefit before you can actually get it approved. So it's not so simple to develop treatments and medications. Many of you know that. But so that has disenfranchised industry from it. With new investments, and to me, the best way of energizing a field is to have a success. So I'm speaking of a success in terms of medication. This is because it's a wonderful success. I think this paper comes in 2006. There was this paper describing a genetic mutation that is encoding for the gene for the NAV, the sodium channel, that basically when the person had that mutation, and those channels were non-functioning, the patient did not feel pain. And as a result of that, there was an enormous amount of investment from industry to get drugs that would block this channel to actually as potential treatments for pain, that were basically addressing excitability of the neurons and nerves. So it's not that you are going after the opioids completely devoid of anything to do with opioids or dopamine. It's affecting the nerve excitability. So if you can block that nerve excitability, your pain signals are not going through. So many, many years of failures and drugs, and until 2025, and this was a study, a product that we funded at NIDA, that it actually is not going after the sodium V1.7, but after the sodium V1.8, that showed that actually is very effective in the management of acute pain, is non-addictive, and its effect sizes in managing pain as not as dramatic as those of opioid for acute pain, but they are very close. So here we have a success story in terms of how we can learn to actually come up with alternative treatments as we delve into information that comes from many, many different fields. And in that space, for example, I think that an area that is very, very interesting and exciting is that I was commenting upon, that of neuromodulation. And how do we, again, harness our neuroplasticity to actually revert the changes that had led to those sensitized responses that produce hyperexcitability in the nervous tissue that generates chronic pain. And again, that may not necessarily per se work for other conditions that have the chronic insult, because that chronic insult and that sensation may be valuable for you to know how you are doing for management. So it may not be totally good that you don't feel any pain if you need to get those signals going on. So this is where we are. The science is in terms of our understanding, the opportunities that we get, also of applying holistic interventions. Because one of the things that we've known is quite effective in handling pain, you can call it, or it can be very, very harmful, is a sleep deprivation. Sleep deprivation enhances pain, and sleep actually improves significantly pain. Exercise is another one of them, and you heard, I don't know if you heard the presentation, and we are starting to understand why is it that physical activity can be so beneficial to pain. So again, is the strategy of not trying to solve everything with one intervention, but recognizing that we not need to limit ourselves to one intervention. We don't do that for any other area of medicine where big advances are happening, like with cancer or with HIV. We use multiple treatments. And there's nothing that's interfering with us to actually take that same strategy and apply both behavioral changes that are known, there is evidence clearly, that have benefit in managing pain and for which we understand some of the mechanisms, but also neuromodulation or therapeutics like this new medication. And with that, I'm going to end up my presentation, 1 minute and 30 seconds, so that we have time for questions.
I have a husband who has pain issues with his hips and his back and osteoarthritis. And how can you tell, as a wife, when someone has moved from that chronic pain response to that secondary type of pain that is chronic, that is more of that, you've created those pathways, but how do you know whether the pain is still from that insult or is real now? I believe him, but it's hard for me as a wife. So.
And I do want to, I want to highlight that pain, even if there's no insult, is incredibly real. I mean, your brain, you can see it if you do brain imaging, you can see the pain signals in the brain. What you cannot maybe seeing is if they have basically related to knee pain, you don't see any more than knee degeneration, but you're seeing it in the brain. So that's where it is. So the way of addressing it is, and basically the clinician that is taking care of the medical condition that produced this, will be evaluating to determine if the insult is present or not. One of the things that happens, even if the insult continues to be present, there's no way that you can explain escape the conditioning and the sensitization pathways. So these things are happening. The issue is that when you do have the insult, you have to focus on controlling that insult, because otherwise it's going to be very, very difficult to manage the pain. And then you can start to work with, among other things, for example, cognitive behavioral interventions that can help the person understand under what context the pain will get worse. For example, pain patients will tell you, you know, it's very strange, I don't understand my pain. I'm more or less very good all day long, and then at night the pain hits me. Well, what happens is that at night you no longer have stimuli that are distracting you. And then you start to dwell, and that insula that I show you there, and the anterior cingulate also is involved with that interoceptive awareness, that rumination, that leads you to concentrate on that experience. And yes, we have the ability in our brain of shifting what is it that we're going to be able to process, because we cannot process everything. Our brain is filtering. And so at night, when you don't have many other stimuli, it's very easy for pain to interrupt itself. It's also the time when we see the compulsive, the drive in people that are taking drugs to get worse. We also see sometimes in terms of suicidal thinking, where you have that ruminatory element on your brain taking over.
I don't understand your diagram about dopamine. I got confused, because it can be pleasurable or it can't. I was confused about that.
Yeah,
I'm
so.
lost. You know what I'm talking about?
Yes, absolutely.
Okay.
Yeah, no, and many scientists were confused by it, because dopamine has been traditionally seen, you give a drug and you're measuring dopamine in the nucleus accumbens, the main center of pleasure in the brain, and it goes up. And then with researchers that were giving pain conditions, and dopamine goes up. So say this pain area is like this, the areas are they are the area where your pain, the dopamine goes up, in that area that we thought initially was pleasure and reward, is different in terms of location. The location is likely different. So, but both of them get stimulated, and that is what drives, is a very important, that's why I call it an energizer. It determines how it's going to be affecting, how much it has the strength to affect your behavior.
So it depends on where it is.
Correct. And the context.
Yes. And one more thing is pain, I guess, especially depression. Can it be a lot like Pavlov's dog?
Absolutely. That's Pavlov's dog. He's the first man that described conditioning. And he described it by observation. And he basically documented it by salivation of the dogs when they heard the bell. That's conditioning. If he had ability to go inside the brain of those animals and measure dopamine, he would see that the bell by itself now increases dopamine. And I mean, it's almost magical. So, of course, the drug, the food, increases dopamine. But if you condition, if you pair them, the brain learns to associate, and it transfers the effect of the food into the bell. And that's conditioning, and that also happens with pain. And that's when we're trying to work with a patient to make them aware what circumstances actually may have conditioned the emergence of the pain sensation.
So maybe the mind control could intervene, like, no, you're not really feeling this, that's just a thought.
Well, yes, I mean, that's one of the things that two things. One of them is by cognitively understanding yourself, what places are at risk, you can avoid them. But also, a lot of what we do, and this is done through meditation, and meditation is one of the practices that is done sometimes for pain, and it helps you do self-regulation such that you can actually basically engage your brain on not focusing on that sensation. So you can use your cortex and you can train it. And I would say there are meditators of people that can tolerate extreme exposure to pain. and they do that only on their meditative practices. So we do have the capacity to do that. And again, one of the opportunities that we have in research, and this was a study that fascinated me when I read it. It came up like 14, 15 years ago, and says, wow. And they were teaching people and says, okay, they put them on an imaging scanner and they are imaging their brain and they're showing their brain to them. So I'm lying in there, I'm seeing my own brain. And they put my hand in extremely cold weather, so I feel pain. And the researcher is telling the person, do whatever you do when you're trying to control your pain. And so as they are trying whatever you do in your own subjective lives, you are seeing how that affects your brain. And that feedback leads you to rapidly learn when you succeed in sort of you do something that actually is activating, where specifically we were looking at that anterior cingulate gyrus, a big signal comes up in your screen. So you know that whatever you do is what you need to do in order to activate the anterior cingulate gyrus, which is necessary to down-regulate the pain. And so this is what we call neurofeedback. And the utilization of these neurofeedback technologies can help you, train you to better self-regulate. Meditation practices or this type of tools can be utilized. I don't know how to check it.
You mentioned, and it was hard for me to read, I'm sorry. You mentioned a breakthrough in 2025 of, I don't know how you pronounce it, Journavx.
The VA, the drug itself.
Okay, so
VA 1.8 antagonist.
I'm sorry?
It's a VA 1.8 channel antagonist.
So I'm wondering if you could say a little about in what circumstances and how that would be prescribed, and is it available publicly and all of those sorts of things. If someone's experiencing chronic pain, would that be something you could ask your physician to prescribe, or is it something else?
Well, no, it depends on the pain condition, and it depends on what the FDA has approved it. What are the indications of pain that it has approved? For now, my understanding is it has been approved for acute pain, but I do not know. And if you shoot me an email, which should be easy for me to get my email, I can get you the information of what are the plans to move it towards. Are they seeking an approval for a chronic pain condition? There was a question over there.
I thought that was a great talk. I'm a neurosurgeon from Australia with an interest in pain. I treat lots of patients with chronic pain. I enjoyed your bold statement at the start of the conference about you were suggesting the cure of addiction with neuromodulation therapies. Is that correct?
Correct, yes.
Can I make another bolder sort of proposition? It appears to me from my years of working in pain that addiction and pain are very closely related. And although we traditionally talk about managing chronic pain, do you see the day in the future where chronic pain is, I don't like to use the word curable, but I think certainly neuromodulation strategies of all stripes are key to managing chronic pain well. Do you see, the potential for cure of chronic pain using those sort of strategies? I'm being deliberately provocative. I know it's not a simple question, but you do see patients who you treat very aggressively in the early stages of acute and even chronic pain who use neuromodulation strategies and their pain seems to disappear into the background. And occasionally you see patients who've had pain for many years who will come in and tell you, I did all these sort of things, I have the pain, I live with it, and you almost fall on the floor in the office as a medical practitioner and you say, this is incredible. You've really learned how to deal with this well. So I'd be interested in your comments along those lines with your expertise in addiction.
Well, I definitively think that, and again, when you have chronic pain, a chronic pain condition where the insult is no longer there, that you could apply this harnessing of neuroplasticity, and one of the strategies is to use neuromodulation, which is being used for management of pain, to address a cure. I think absolutely, I believe this is plausible. And I think that it is, again, an issue of combination. So one of the strategies that we're testing is very early on research, even though there have been interest for many, many decades, is the use of psychedelic drugs because they have the ability to accelerate neuroplasticity. So you saw that from long-term potentiation, long-term depression. When someone takes, for example, psilocybin or LSD, you actually accelerate the formation of those synapses and also or their degradation. So researchers are now looking at it from the perspective of pain. We are funding researchers to look at it from the perspective about how to utilize it for the potential to accelerate changes that are necessary for that neuroplasticity to happen. And we are viewing it not as isolated that you get psilocybin itself and it's going to cure you, but in combination with a therapeutic intervention. So if you are trying to do, for example, neuromodulation to block the sensation of pain, how about doing that when you are under the effects of psilocybin, which actually is going to generate that signal? That's where we are right now trying to push and nudge the research to go into strategies of how can we learn to actually use that neuroplasticity to reshape the brain into health and then achieve cures that in the past we hadn't been bold enough to even think about.
I went to your lecture last night about the GLP-1s and use of those in addiction and chronic pain. Do you, I guess chronic pain, that's my question. Are they geared towards chronic pain or acute pain as far as using those with the decrease in inflammation?
The decrease in inflammation probably, I mean, in terms of what may be their value for acute pain, I think that would maybe, and you have some of the experts here on the industry, not the top priority is the chronic pain that becomes extremely, extremely challenging, and where we know inflammation plays a key role. So a lot of the neuroinflammatory process driven low back pain, knee pain, joint pain, absolute this. Some of the pain from autoimmune diseases also are from inflammatory processes. And I think that, as I mentioned yesterday in the talk, I think that the fact that we are seeing so many pleiotropic beneficial effects of these drugs is in a way pointing how extraordinarily important inflammation and how devastating obesity is, in as much as it also promotes inflammation, for the health of all of our bodies, including pain. And yes, pain is much more prevalent in people that have obesity and in people that have diabetes.
Do you think that the GLP-1s interacting with the body to decrease inflammation because of obesity, does it also decrease inflammation because of autoimmune issues or just obesity? Is it inflammation all around or just because of knee pain because you're heavy and you're on your knees?
It goes beyond weight loss, and they see benefit in people that do not lose weight. And that's what...
As an athlete, he doesn't need to lose weight, and I was like, we need to look into this, and he's like, I don't want to take that because I'm not heavy, and he thinks it's like a moral issue, not a, you know.
No, these are nothing to do with moral issues at all. Yeah, no, I know. But it is, I mean, and we have to, even though it's pretty obvious, we have to repeat oneself because people fall very easily into that trap. And I think that, yes, they do look promising as anti-inflammatory drugs. And in just basically looking, because now we have, as I mentioned yesterday, many, many years of electronic health records with patients with various conditions, and we can try to see on where there are signals of benefit. And there are many, many conditions that may have in common that inflammatory process. I think we have 53 seconds. Well, thanks very much for the questions. They've been great, and enjoy the rest of the meeting. Thanks.